Sorry.
Good morning.
Hello, Dr. Aarti. Am I audible?
Yes, ma'am. Just give us.
Okay. Few more minutes. Can I join later? Few more minutes later?
No, I would want you to be on. We should be starting in a few minutes. So please be on.
Hi, Aarti. I'm there. Am I audible, Aarti?
Yes, Rajni, but I can't see you, Rajni.
I haven't switched it on.
Okay,
My video.
okay.
I was in the middle of something.
Great. All right, no problem. Thank you
Yeah.
for joining in. Thank you.
Hello, Rajeshwari.
A very warm welcome to all the family members, users, mental health professionals who have joined us today. Today, we're going to discuss and understand about a very important topic, that is the assisted home care services for persons with mental illness. This is a very innovative initiative, which actually was a need-based initiative brought out by the family caregivers and was very, very vehemently advocated by them to the government, because of which the government of Karnataka requested Nimhans to initiate this entire project sometime around early this year. So we are going to have two presentations today. We're going to first, after the introductions, request Dr. Nirmala Srinivasan, who is also the founder of FACEMI India, and who has been advocating for assisted home care services, to present the point of view that they've been talking to the government. We then have our team of the assisted home care services over here at Nimhans, who have been working on this project, and we will discuss with you and present to you what we have been doing over here, what is the proposal, and what is the work that we have done till date. And then we'll open it up for questions. I am happy to be joined in online by Dr. Rajani, who is the Deputy Director, Mental Health. Dr. Rajani, thank you so much for joining in. She's also a co-investigator in this project and a huge support. We also have Dr. Krishna Prasad, who's joined us online today, who is the primary investigator for this program. And we have Dr. Virupaksha, who's a co-investigator, who will be joining us after a short time because he's engaged in another meeting as of now. So I will request my team over here to introduce ourselves. And since we have quite a few participants, 75 of them as of now, and I'm sure the numbers only grow, I don't think we can have introductions of everybody. So you can type in your name and your from where you are on the chat, so that it is recorded for us, and it is helpful for us for our records. I request all of you to introduce yourself on chat, your name and from where you are, and if you are a user, a family member, mental health professional, that would be helpful. So I am Dr. Aarti Jagannathan, additional professor from the Department of Psychiatric Social Work, working in the Department of Psychiatric Rehabilitation Services. I'll pass it on to my colleagues.
Myself, I'm Dr. Bindhu Sagar. I'm working as a senior resident psychiatry in assisted home care project.
Myself, Catherine Joseph. I am working in assisted home care as a social worker.
Myself, Yogesh Kumar Gaud, working as a community nurse.
Hello everyone, my name is Rugozevou. I'm a PhD scholar from Psychiatric Social Work Department, and I'm part of the coordinating team for this program.
Good afternoon, everyone. I'm Dr. Ramya. I'm non-PG junior resident in ERS, and I've helped the coordinating.
Thank you to the entire team.
Doctor.
Yeah, and I would now request and hand over the floor to Dr. Nirmala Srinivasan to present her point of view. Madam, please do let us know if you want us to present the PPT, or you will do the needful. Kindly let us know.
Yeah, thank you so much, Aarti. And thanks to you and the team. I'm finally see a face behind the program. I'm
Sorry
so
to interrupt. Aarti, I thought I'll just tell that I'm there. Dr. Rajani here, Deputy Director, Mental Health and Nodal Officer for the Assisted Home Care from Karnataka Government Health and Family Welfare Department. Yeah,
thank you so much. Thank you so much, Rajani. Rajani, would you want to say a few things? Because I think Rajani has to leave for another government meeting by 2:45-3. Do you want to say a few words? Because we don't know whether we can catch up with you later on. So we will make notes, but Rajani, if you can just set the stage, and then so that then we can start.
Before Rajani, can I just say a few things to Government of Karnataka through Rajani, and then she can take over. Hi, Dr. Rajani. So nice So nice to hear you. I mean, we have gone through it from the beginning.
Yes.
And short of calling it harassment, you know how we have been advocating for this program. Thank you very much for all that you have done and given us a hand-holding. It's now over to you, please.
Yeah, thank you, ma'am. So thanks for all the participants who have joined and who are going to be joining shortly. Actually, I think from 2016, after I took charge as Deputy Director Mental Health, myself, Aarti, Nimhans team, Nirmala ma'am, we have been discussing many times arguments, various, other things have happened. And now we have actually started assisted home care after so many years, thanks to NHM, Government of India also, who have accepted our innovations. So we have started assisted home care pilot in Bangalore urban district. We have learnings from that, which I'm sure Aarti and team will be presenting today. So based on the learnings, we are planning to expand it across the state. So that's what I want to say. So that's it from my side to start with. In between, if there are any things, I think we will take it up.
Thank you so much, Dr. Rajani, for being a support and joining today. I know you're on leave, but you've joined. I mean, thank you so much for that. Dr.
Yes,
Nirmala,
I was on leave.
Yeah, thank you. Thank you, Rajani. I'll hand it over to Dr. Nirmala, and ma'am, please let us know if you need any assistance in the slides. But the floor is yours.
Thank you very much, Dr. Rajani. Thank you for that.
Yeah, floor is yours for the next 20 minutes, ma'am. Thank you.
Okay. Thank you for the positive news you shared with us just now. It is so happy to see that you're going to expand the program. So I always keep my fingers crossed, being a pilot, what will be the fate of this program. So now that you have given me an assurance you're going to expand it, I'm very happy about it. And whatever I'm presenting today, the idea behind assisted home care, it's a teamwork from me and the other members in FACEMI and especially Maitri Bangalore. And what I'm going to say today is not exactly what Nimhans is currently running the program or implementing in Bangalore Urban. I'm yet to see myself. For the first time, I will have the pleasure of listening to the Nimhans team. But there is, I'm sure it's based on it, but not exactly from theory to field. A lot of changes can take place. So, and also midterm review, so on and so forth. What is most important, the critical feature, the whatever you call it, the very important feature of this program, whether it's run by Nimhans or the design done by me as on the drawing board, whatever it is touching the families, the lives of the families, our day-to-day problem, and that is most important. And the fact that Nimhans has just started 3 months back, the program has been rolled out. And the fact that they are ready to share it across India with all of us family members, I'm so touched by it. Least of all to say I'm touched by it. Dr. Aarti, my compliments and greetings to all of you. Thank you so much. We are all there to go along with you. Try not only just give a feedback, to give a hand wherever you need our help. That is all I want. And with that now, let me try to share the transparencies. Whatever, if I can't, then I'll take the help of your team. Yeah. Now, oh God, I left the meeting, I think.
You're very much in the meeting, and we can hear you.
Yes, 1 minute. Yes, I think I can manage it. Is it on? Are you all able to see it?
Yes, ma'am, we can see it. You just have to go on to the full screen mode.
And full screen mode is a little tough. I'm not able to see
it. No, it's F5, I think. You just need to press F5.
F5, is it?
Yes, F5 on your keyboard.
Yes. Yeah.
Yes, ma'am, you're on film screen. Please go ahead. Thank you.
And from the full screen to go to the next one, next transparency is possible, I suppose.
You can just press the down arrow key. It will keep going to the next. The upper arrow key will go to the previous one.
Yeah. Anyway, the previous slide was the title one. So all of you have already know my introduction. Now I'm this transparency. Is it clear, Aarti, the full screen?
The full screen is not showing. There's some cut, but I think you can go ahead. That's okay. Yes, almost 95% of it is there.
No,
so it's okay.
I'm gone ahead. I know I have to come back now again.
Yeah, so you just press the back, the arrow keys, then you will come back.
Yeah. Is it okay if I keep it full screen?
Okay, sure. Please go ahead.
Is it visible to others?
Yes.
Because the full screen is a little too challenging on my eyesight here.
Done. Please go ahead, please.
Okay. So now, before we go to the transparency, it's a very important question. Who exactly, now this is assisted home care for mental illness. That is those people under psychiatric treatment, those who need of one or those who are already under treatment for one. This is only for that people. It's a model is versatile enough to be adapted for autism or MR or whatever it is. But now my presentation is for mental illness here. Now, who are the people? Who are PMIs? PMIs are persons with mental illness. And in India, who are the people who take care of them? Because they do need, not necessarily take care is a very broad term, but we all understand, most of us being family members here and mental health professionals. There are 4 types of care models, 4 types of agencies who provide care for persons with mental illness. Mental health institutions, national and state level. And then, of course, in mental health institutions, sometimes they're admitted or sometimes they're admitted people who cannot get back home or kept there in spite of Supreme Court order not to keep them in, so those who are recovered at least. But there is that's a debatable issue. I'm not going into it. So institutional care is very familiar, known to all of us. So also the next one, community care. Community care is where there are homes kept, like charity homes, Mother Teresa's homes, or where there are paid services run by private mental health, like, for example, Richmond Fellowship or Medico-Pastoral. There are homes within government, destitute homes. Manasa Rehabilitation Center all over Karnataka is very well known. Private rehabilitation centers are known. So these are all community care models. So we have institution community care. Then comes family care, where you and I belong to. Family care is the largest care provider. 65% to 70% of persons with mental illness. These statistics, whatever I quote, are got a source. Those who are interested can contact me. I will give you the source of the statistics. 65 to 70% of PMIs in India are cared for by families. This is a new paradigm, new model that I have introduced. People are only institutional care, community care. Beyond that, usually I've never heard in any of the academic presentations or meetings, people only talk about community-based rehabilitation, community-based treatment, community-based care. But where is the question of family care? Many families don't reach the community. Community almost becomes a myth for families. So where is the question of family care gone? That is the quintessential feature of this program. Assisted home care is highlighting the family care model, and it is time that we highlight the family care model because it is the family which contributes a lot to the upkeep and maintenance, as you say, whatever, to the quality of life of the person with mental illness. The last care model is street care for those with shelterless, homeless persons. That's very familiar. I'm not going to here. Our focus in this presentation is on family care because I am familiar with family care. I'm not very familiar with other models of care. And this, in my view, and in view of almost all the families across India, we have a network across India. Our FACEMI group is a pan-Indian organization. And from the way the narratives that pour in every day almost into our groups or in our phone calls, shows that family care is the desperate need of the for Government of India projects or any projects in mental health. So What is family care? It's easy to say family care. People are taken care of in families. Simple way, our simplistic way of saying it, I would say. I try to sort of make it little more, give it a professional touch so that we have a meeting point between the professionals and the families. It is the care quotient of special families. Now, care quotient is a word I borrowed from business economics. Care quotient is something where the businessman or the proprietor, whoever is in charge of the business, takes care of the business and takes care of his personal growth, his or her personal growth. So, special families here are families. Obviously, you all are aware of it. Is families with loved ones and need for any special needs in terms of their disabilities or illness or whatever it is. So, care quotient of special families is family care, as I would explain. What is this care quotient? The care quotient is the routine need of all families, whether they are affected families, whether they provide care for mentally ill or disabled. It's not. It's a saga of life, as I put it, little metaphysics here. Saga of life. All families go through it, rich and poor, social, medical, financial, healthcare needs, education, recreational, care of senior citizens in the family, grandparents, career decisions for children who are going up, jobs, marriage, retirement decisions, all ups and downs of life. Routine needs of all families. But those special families, the families who provide care for persons with mental illness in this context, in addition to these routine needs, they have needs of the loved one with mental illness to take care of. And this plus, which you see the symbol, the blue plus cross here, you see, that makes all the significant difference in the quality of life for the family itself, for the person suffering, most importantly for the person suffering. I would put the person PMI in front over and above the pain and suffering of the family. They face challenges at all levels, starting in addition to the routine day-to-day, daily commitments, routine needs of families, what I call the saga of life. There are challenges at all levels, treatment needs involving early intervention, follow-up care, activities, schedule, social network, financial, legal help, life care, long-term care. So that are two divided, one above the other. And this is a responsibility. I don't like the word burden of care. As far as possible, I try to discourage the word burden of care, because after all, we are looking after a loved one in the family. It can't be a burden. We like to say instead, substitute with the word responsibility of care. So the responsibility of care of a loved one in the family with mental illness, in addition to the care that we have to provide, look after, as they say, running a family. Sometimes people ask, what is there to run in a family? Each one does their job. But the most important, the moot point lies in there. If each one can do their job, where is the question of problems in a family? So all this put together, the quality of life of running the mainstream family needs, added together with the responsibility of care for the person with mental illness, defines the care quotient of special families. And this I would call as family care. I would like you professionals in the team to find out a formula for it. I'm very fond of quantification, though it's my weakest subject. I don't know how to, but I love that. Calculate care quotient, find out the parameters in it and variables in it. And it will be a very interesting thing for you people, especially those PhD students, to work on. And more we quantify, the easier it becomes to deploy resources for all of us. And it's easier for you, even in therapy, you can add these things without using the jargon, of course. So this is family care, the care quotient. So the persons in the family carers, I don't like the word caregivers again, as far as possible. In FACEMI, we try to discourage the word caregivers. We call ourselves family care and loved ones. We enjoy the responsibility of care. We are desperate to provide them quality. After all, it's a matter of, my son is my flesh and blood. So where is the question of giving him care? I embrace him with care. These are very important emotional terms we have to use. And I'm not trying to say you should use it in your assisted home care program, but I am expressing being authentic to my role as a spontaneous expression as a mother. So here comes the question of two challenges. I have to take care of myself, take care of other children in the family or other members of the family, and also take care of the loved one who needs additional help, who needs support. This care quotient is very, very important, and as if to give us all a breakthrough, the Mental Health Care Act 2017 came out with a lot of promises in the form of rights. And in my personal view, this assisted home care program is rights-based and has to be rights-based to make it easy for all of us. And these rights are such as if they've been a panacea, as if it is a gift of God to all of us looking for solutions hitherto not known, going to the court with PILs and writ petitions. Even I've gone to the Supreme Court. But these have now become rights. What is most important of all is Section 18.1 of the Act mandates the government to provide psychiatric services. It's my right to access psychiatric services from any government hospital, whether it's Nimhans or Victoria Hospital in Bangalore to say. So each state has its own district hospitals, government hospital with psychiatric departments. And in addition to that, there are DMHP programs. Dr. Rajani is in charge of Karnataka DMHP program. All the districts have DMHP clinics with psychiatrists in it. Across India, 652 districts, I think, if I'm not wrong. So all of them are equipped with a team of DMHP professionals. A team is very important. We rarely find a team in private clinics or private, especially in private psychiatrist homes, yes. General hospitals, sometimes yes, sometimes no. And this team is the psychiatrist, the psychiatric social worker, the nurse, the clinical psychologist, and one poor person to run the ambulance and all that. If I'm wrong, please correct me. So this team is there all over India. This team, accessing the help from this team is a right under this act. So many other rights we have been given. Emergency ambulance service, psychiatric services near one's own residence, provision of halfway homes, sheltered homes, supported accommodation. We'll go into detail. We may not be able to give the details, but question answer session maybe. Provision of mental health services to support the family of the person with mental illness. Please underline, I should have put it in bold. Home-based rehabilitation. These are words from the legislation. These are not my words, passed by the parliament of this country. So you and I have a right to access all this. It is very nice breakthrough, very welcome breakthrough. 2017, we are very proud of India for having passed this legislation. But then, legal reality is different to social reality, especially in mental illness, where the social ramifications are unpredictable. Every day we have new challenges. For example, recently, 4 or 5 cases, one of our members, very well known in our stakeholder circle, Vijay Nalawala, brought up 4 or 5 cases of dishousing. Middle class, low middle class families sending their parents out of the, sending their PMIs, loved ones out of the house because they're not taking medicines. They're telling them, get lost, get out. I cannot provide care for you anymore. This is not happening in poverty-stricken slum families. This is happening in urban cities. I cannot disclose more reasons. We are wondering how to go about it. So all these kinds of new problems are being faced. So in spite of Government of India providing all this, there are challenges which we are still not able to, unfortunately, cope with. And I earnestly, on behalf of all the family members here, I plead to the Government of India, please have more and more family-centric programs. Please divert your resources from community-based programs to family-centric programs. Use family care model as an independent variable. So when we see why this, see the box 1, why are families not able to avail of all these promises which government has given? First and foremost, the reluctance or resistance of the PMI or the family to visit psychiatry OPD facilities. So like in any other specialty, you don't get a specialist to come home. Cardiologists won't come home, specialists. Pulmonologists won't come home. We have to go there. So also psychiatrists can't come home. There's nothing wrong in it. It's probably their medical code or whatever it is. But then here there is a problem here in mental illness, as you all know, is a resistance. Either family's resistance or patient's resistance to go home, to visit the OPD clinic. As a result, whether it's private clinic or government, they are not but private, next door. The DMHP center may be next door, but still the family won't be seen there. This is not surprising. As a result of the second reason, slow or nil implementation of the Act. And all of you know that the legislation about it, we have some members of the Central Mental Health Authority from families, Government of India, who have joined us for this program. I welcome Mamta, Lavanya and Janvi. I think, I'm not sure others who have joined, but they have joined. They must understand. They will know. Please share with us what is the latest update on the implementation of the Act. Very slow, nil, it's not nil. The third reason is ignorance of the laws and rights by the families. Many families don't even know there is an emergency, right to emergency ambulance. They don't know. They pay in a crisis, families just 15,000-20,000, hands and legs tied. That is how it is being done even today, in spite of such a noble, magnanimous legislation that we have. They're dragged. Even animals these days, the Animal Act or whatever it is, even animals, people don't tie their legs and hands and take it. The families don't know there is a right to ambulance, public health ambulance, free ambulance. In fact, our Mumbai group, their first agenda of advocacy right now is ambulance, 108. And I compliment the group. They've all joined here, I think. I congratulate for identifying that as one of the... In Mumbai, somebody pays 30,000-35,000 for shifting a patient. That is where the problem, ignorance of the law. As a result of a combination of all the three factors in box 1, we have low care quotient of families. You remember the word care quotient? Very low. They are neither able to take care of the other members nor the PMIs, the family in a turmoil, violence, escalation of crisis. There is an uneasy peace in families, even though there is no violence. I don't know how many of you feel. Everything is fine, but not so fine. I don't know what word to put it. Kind of uneasy peace is around us. Sometimes criminal outcomes, daily upheavals, fights which you don't. Peace. I mean, it's very tough. And then the children, the milestone of other members of the family affected. All this is a result of box 1. And the final culmination of this at a micro level, what the government or the professionals call as burden of care on families. The burden is not because of her loved one. The burden is not because of the illness. The burden is because the system has failed us. And assisted home care, I'm so grateful to all of you, Government of India, Nimhans, and Government of Karnataka for having piloted this. And I hope, and my wish is to see all over India very soon. My micro is burden of care. Macro level is 80 to 90% treatment gap in India. So because of this treatment gap, why is 80 to 90%? Because 60 to 70% of population, people, PMIs in family care are not being touched by the OPDs clinics across India unless they go. 2 out of 10 people visit the OPD clinics. Dropout of treatment in India, dropout ranges from 14% in some states to 64% in other states. People drop out of treatment. Dropout is an easy word. It's a statistical terminology for others. For families, I can't even say what it is. I don't have a word to say it. Dropping out of treatment is just not a nightmare. I don't know what to say it. We can't face the world, the community again after all these tragedies happen. And therefore we come to Considering all this, I decided families, in order to improve the care quotient, we need hand-holding on the spot. So before I go to what is assisted home care, let me say what is not assisted home care. I'm quickly reading through it. It is not emergency care. On the other hand, it helps to reduce or eliminate emergencies by fulfilling the unmet needs of the families. AHC is not required for all families. It doesn't require psychiatrists to make home visits. This is very important information. Families, please understand. Don't have high expectations. Psychiatrists can't visit homes. It is not necessarily free, but it is affordable, for which diverse types of financial models under public-private partnership and government grants are necessary. I won't go into details, but it's a very versatile thing across India. One size does not fit all, as they say. So one model in Bangalore urban may not fit Mumbai urban or Delhi. As such, we have to have multiple models, and financed also, funded and subsidized for middle-class families especially. NGOs with exposure to and experience with MEMI can also set up assisted home care with license from Government of India. So what is assisted home care? Finally, I'm coming to it. As you all must remember, we are still talking about the care quotient of family members, hand-holding in their problem. Assisted home care implies doorstep delivery of a range of medical and non-medical services on a routine basis. Stitch-on-time principle of spot help in one's own family. It also envisages holistic covering end-to-end care, legally backed up by the MHC Act 2017 and RPWD Act 2016. It means related to treatment. It is related to treatment, medication, rehabilitation, therapy for PMI and family, including information on legal and long-term care as well. Assisted home care is within the framework of the rights under section 18.1 to 18.C, 5A, B, and C of the Mental Health Care Act. In brief, this is how it works, the flow of services. We have 3 red boxes, and these 3 red boxes are the 3 verticals. The first, assisted home care, is assisted Medicare. The second one is assisted rehab care, and third one is assisted recovery care. Broadly putting in the chronological phases in which we go through. I mean, this looks very neat and tidy on this frame PPT, but as you all know, it doesn't happen this way. Just as we think the medicine is suiting the person, suddenly there may be a relapse, or the person stops taking medicine, doctor wants to introduce another medicine, doctor wants to say, okay, ECTs may be helpful. And ECTs, we have a lot of doubts, expectations high. You all know the kind of hide and seek life plays with all of us. So it's not so easy. But assisted Medicare starts fundamental, basic. These are modular programs. You can take, and it's also not necessary for every family to call the team to go through all this. Some family may want only legal help. Their patient may be taking their PMI may be taking medicines regularly, compliant, going to work, absolutely no problem. But they want to know how to hand over the property, or can they inherit property, can they manage their own property, how to appoint a guardian. Legal information only. The team is ready with that. For the legal information, the assisted home care team has to collaborate with the disability department of their various state governments. For example, disability department in Karnataka and Dr. Rajani, the Aarti's team will be collaborating with each other. The link person, the liaison person will be a social work team, for member of the team, to link the family with the Department of Disability or the guardianship or the legal services authority, so on and so forth. So it's a medical plus non-medical, end-to-end service. You have here so many things. I don't want to go through the boxes, but those of you who are interested. So this is the final transparency. A knock at the door, as I call it, helps us. Assisted Medicare with this, diagnosis, therapy, follow-up and all that. Assisted rehab care, which is employment skills, training, job skills, career planning. Then finally, you have assisted recovery care, long-term legal aid, supported accommodation, family therapy, so on and so forth. You can fix in all this. The most important is, of all the things to begin with, I would give importance to Medicare. Of course, there are cases, as the psychiatrists would be saying, there are cases which may not need medication, but where therapy is very important. So such prescriptions, whether it's medical prescription is not the only prescription. Sometimes family therapy may be the only prescription, nothing else. Or sometimes no prescription. So all this comes into various boxes. And each one of these boxes, I can link it to one section in the Mental Health Care Act or in the RPW Act. So it's a right of the families, right of the family. Family, I'm using it in a very inclusive sense. When I say family, it doesn't mean only caregivers. Families include everyone, the loved ones under treatment as well as the family cares. So for all of us, this is the model that I'm suggesting. And with this, I wish to thank all of you. I hope I've not taken too much time.
Thank you so much, Dr. Nirmala. You've been bang on time, I should say. You can actually stop sharing your screen so that we can see you.
Yeah, I'm trying to learn how to do that.
On top, you will have stop sharing. So
yes.
Sharing. Yeah, great. Thank you so much, Nirmala ma'am. I think it's been a very good perspective that you have given us. And when I now hand over to my team, who is working with us over here in the AHC, you would realize that there are some components of what you said that is being covered. I don't know whether Dr. Rajani is still there. Dr. Rajani, if you're there, I just wanted to bring in the point of what Dr. Nirmala said about rehabilitation and recovery. And I think it's very nice to bring in that we have started the Taluk mental health program along with your support. And we are actually doing what Dr. Nirmala suggested beyond the Medicare of rehabilitation and recovery through our 10 Taluk social workers who are there. So if you want to just briefly talk about that.
Yeah. So basically, we in Karnataka, we started implementing district mental health program across the state from 2016. After about 2 years, we actually proposed to take in the first phase 10 Taluk hospitals also, wherein we have recruited one psychiatrist and one social worker. So by doing this, I think Karnataka is the first state to start Taluka mental health program. Other states, I'm not sure whether they have started. And also one more thing is that through our Mano Chaitanya program, all the 146 taluks are covered, wherein we call it as Super Tuesday clinics. So we actually, our district mental health program teams, they travel to the taluka hospitals, that is sub-district hospitals, on specific Tuesdays and Fridays, and they cater to the need of the person with mental illness at the taluk hospital itself. And we also train the medical officers across the state in all the PHCs. And now it has gone down below that. Happy to share that we have around 6,000 plus community health officers. This is one of the flagship program health and wellness centers across the state. We have more than 6,000 operational health and wellness centers in the state. And we also have CHOs who are the nurses. So each sub-center has a nurse who is also being trained under mental health so that she or he can screen those people who come there, and it helps for early identification. As you know, it may start just with a mental distress and it may not go, most of the time they need help when they are in crisis. So that is how it is. So we have covered all the, in a nutshell, we have moved down from district mental health program to taluka mental health program. In the taluka mental health program, in the 10 taluks, we have a psychiatrist and social worker. And then through Mano Chaitanya program, we are covering all the taluks. And we have started many pilots like suicide prevention program, Kishore Swavlamban program, wherein we train the volunteers and school teachers and students so that they seek help when in need, because most of the patients whom we see as adults, at least 40% of them would have not become psychiatric patients if they had that good nurturing and care during their child and when they were children and adolescents. So, and then we also have care at doorstep by community volunteers, which is being piloted, and then the assisted home care and various other programs also we are planning to start. So thank you, Aarti. That's it.
Thank you, Dr. Rajani. I think since Nimhans is involved in the Taluk mental health program along with your team, the main aim of the Taluk mental health program was going beyond medical assistance.
Correct.
And looking specifically at rehabilitation. So we have trained all our Taluk.
In 10 taluks, we have identified more than 900 persons with severe mental disorder. Here, not only the Medicare, if he needs some disability benefit, that is being given. Family is made aware how to take care of the person, how not to misbehave, or how not care for this person. So various other things. If he needs anything else like social benefit schemes are also told to them. So it's a holistic care rather than just the Medicare.
Yes,
that's
so
what
I do remember that
there.
we also have vocational rehabilitation. We have a number of home visits that are done to help the client, to help the family deal with the client and bring the client to the PHC or provide medications and care at the doorsteps. I think the Taluk mental health program is a flagship program which is also looking at this. And as Dr. Rajani said, if you're looking at expanding the AHC, maybe we could look at a combination of the TMHP and the AHC with the current position that is, and see how to expand the whole thing. We have experience.
Okay.
Thank you so much. Now I'll pass it on to my team, my AHC team, who is over here. We have Dr. Bindhu Sagar, who's our senior resident, and we have Catherine, who's our social worker, and Yogesh, our psychiatrist nurse. And I will hand over to them to make a presentation. Catherine will first present on the proposal that we have put forth to the government in collaboration with the government as to what we are going to be doing in AHC and what we are doing. And Dr. Bindhu Sagar will present the data that we have done, work that we have done till date. Over to both of you. Enable editing. No. Enable editing. I hope everybody can see the screen.
Yeah.
Great. Thank you so much. No, I think. Stop. Catherine is coming. Yeah. Yes, please go ahead, Catherine.
Hi, I am Catherine. I'm the social worker in this working in this project. I will be telling about the assistant home care person with mental illnesses. This is a collaboration between the National Health Mission and the Government of Karnataka, Nimhans, Bangalore. These are the investigators of the project. The aim of the project is to fulfill the mental health services delivered as it emphasizes on the Chapter 5 of Mental Health Care Act, where the provision for mental health care services to support families and persons with mental illnesses or home-based rehabilitation, and provides treatment in a manner which supports person with mental illnesses to live in the community and with their families. About the project, as a part of assistant home care, we provide home-based psychiatric services, rehabilitation services, teleconsultation, and referrals by a team of psychiatrists, social worker, and community nurse. The objectives are to assess the need of the assistant home care services for patients with psychiatric disorders in the city of Bangalore. To implement the assistant home care services for patients with psychiatric disorders in the city of Bangalore, and to study the feasibility and outcome of the assistant home care helpline. The need...
is everybody able to hear Catherine? Dr. Rajani,
Aarti, we can hear. We can hear.
Great, because we're getting some chat things. So I'd request those who cannot hear to possibly check your audio systems, because I think others can hear. Catherine, please go ahead. Yeah.
So in India, the awareness about the psychiatric disorder is minimal and health-seeking behavior is significantly low. According to the National Mental Health Survey that was conducted in 2015 to 16, the treatment gap for any mental health disorder in India was reported to be as high as 83%. An effective intervention was needed to focus on reducing the treatment gap for improving the outcome. The COVID-19 pandemic has added to the challenges for the delivery of mental health intervention. There is a need to cater to the patients who cannot visit hospitals due to various logistic issues related to the support without burdening the current mental health care delivery mechanism that are currently in place. The methods are, the geographical area is Bangalore urban. This time frame of the project is 24 months. Initially, it was 12 months and 12 months recruitment and 12 months we'll have a follow-up. The benefactor population is approximately 800 patients and the families in first 12 months of recruitment. The documentation and statistics analysis was done.
Now you're good.
The inclusion criteria of the patients is they should be residents of Bangalore. They should have psychiatric disorder. They should have consent and residing in home with a guardian. Genuine reason for not attending healthcare facilities should be there. The patient included if he or she is refusing hospital visit or logistic issue or any risk are included in the criteria for the project. The exclusion criteria is highly disputed behavior, high suicidal risk and homicidal risk, medical illness requirement of IP care, and intoxication. And if there is legal issue, we will be excluding. The team facilitates referral to hospital, crisis intervention, ambulance service, and police services for them.
Sorry, we need to move this slide. Yeah, no, move.
This is the flow chart. The patient, call is attended by the social worker and the community nurse. Initially, the assessment is done telephonically, and verbal consent is taken from the patient and the family. Callers fitting in the exclusion criteria would be provided appropriate advice, which includes care centers, ambulance services, police station services, etc. The recruited callers, home visit, we do home visit for home care or teleconsultation for prior appointment by the psychiatrist, the social worker, and nurse as per the roster. Assessment and treatment. Assessment and treatment will be provided by the psychiatrist. Social worker and the community nurse will be providing psychoeducation and discussing and implementing the follow-up plan for them. The efforts will be made to enable the patients to recover facility-based care. If not, follow-up care will teleconsultation or home visit is done. The psychiatrist and the social worker would visit the patient to their residence once every month in person as part of follow-up for 6 months. This is the Google form that we fill after the calls to keep it documented. Their supervision of the team is done. Weekly meetings for the whole team, which consists of supervising consultant in the institute, psychiatrist, the social worker, and community nurse. Monthly meetings are done with the in-charge consultant. The outcome and the prognosis of the psychiatric disease as follow-up and management is ensured. This will reduce the disability, hence burden on the family and the society. Indirectly, will reduce the pressure already existing in institute that cater to this population. The outcome may also help in formulating the national mental health delivery system. The outcome indicators are acceptability of the service, number of patients and families who call the helpline, who are visited at their home and who included with reason and advice provided, the intention in follow-up, clinical global impression, severity of the baseline and follow-up, visual analog scale that measures the changes in 3 most important psychiatric and rehabilitation need at the baseline, family burden interview schedule at the baseline at 1 year follow-up. Thank you.
Thank you so much, Catherine. I will now request Dr. Bindhu Sagar to talk about the work that we have done from the start of the project to now, and then we will open it up for questions. So if you have any questions, please type it in chat so that we can take them one by one. Dr. Bindhu Sagar. I hope everybody is able to see the screen. All right. Thank you so much.
Thank you, ma'am. I'm Dr. Bindhu Sagar. I'm working as a senior resident psychiatry in Nimhans and in this assisted home care project. Today, I'll be talking briefly about the experiential account of assisted home care project. Highlights since the project started, I wanted to enumerate few of them. In December, we had given letter to the Dean and Member Secretary of Behavioral Sciences, Nimhans, requesting for the ethical clearance of the current running project. And on 4th of January, we had advertised for the various posts of the research team, that is to senior residents, to social workers, to community nurses. On 1st of March, we had taken interview for the shortlisted applicants of the for the project, and between 27 March to 24th of April, 2 senior residents, 2 social workers had joined. During the same time, we had formed the SOPs and consent forms for the home visit. We had also got the permission from the medical superintendent Nimhans to create a UHD for the subjects who will be benefiting from the project. Since before the staff of the project got recruited to the AHC project, it was the helpline was being managed by the staff of other project. So slowly they were phased out. Those who were managing calls from the staff who were managing calls from the other project. There was a press release about the project on 1st of April in 2023, following which we noted slight increase in the number of inbound calls. We had also formed the posters for advertisement of the project, and there was also a recorded interview about the project from Dr. Jagdish sir and Dr. Krishna Prasad sir on Chintana TV and radio program, which is conducted by Ministry of Health and Family Welfare Department under Karnataka State Mental Health Authority. This was the paper clipping from the initial press release, and these two are the posters that have been prepared for the project. One is in Kannada and one is in English. These posters have been circulated to various stakeholders and hospitals also. Hurdles faced till now are the re-advertisement for the post of community nurse, which was re-advertised twice, excluding the one which was advertised initially. And currently only 3 out of 6 staffs are currently in the project, and 3 more are yet to be recruited. And day before yesterday, interview has happened for senior resident and social workers. They are expected to join soon. There was issues in online registration process to generate UHID due to server issues in official Nimhans website. But later we had got permission from medical superintendent to utilize medical record section of Nimhans to generate UHID for the study subjects. There was a delay in getting the utilization certificate and statement of expenditure of previous financial year. So the release of the fund for the financial year 2023-2024 was delayed. It was in third week of June, and project staff have worked without pay for 4 months from April to July of this financial year. These are the total calls we have made. There are total 48 inbound calls, 139 outbound calls. That is, this is excluding the calls with invalid numbers and no response numbers. There are total 292 outbound calls which are invalid and no response. These outbound calls have been made from the list that we have got from the BBMP DMHP program, where the patients had dropped out of the program. We tried to reach out to them using our helpline, and the total calls till now have been made are 479. There are total 8 teleconsultations that have been made, and 5 teleconsultations we had scheduled, but there was no response from the family. Follow-up teleconsultations are total 31, and 5 home visits we have done. This is the data finding of the inbound calls, that is 48 inbound calls what we have made, what we had got. There were 3 child and adolescent patients, 19 geriatric population patients, and 26 patients from age group of 18 to 60. Mean age of this patient, total patients were 30 years. There were total 22 male patients and 26 female patients. The main complaints we had got were 16 patients complaining about having mood symptoms, 12 patients mainly having anxiety symptoms, 5 patients with psychotic symptoms, 5 with dementia, 3 patients with IDD and autism, 1 with Parkinson's disease, and 6 patients we were not able to clearly assess before doing a teleconsultation. There were 8 calls we had received for the emergency, which was psychiatry emergency, that is aggression and suicide. There were 8 calls that was received. We had to refer them to the nearby mental health facilities. Patients with medical comorbidities were also contacted. Of total 17 patients, 11 were elderly with elderly population. These are the findings of home visits and teleconsultation that we have made, of total 10 tele and home visits. We have done in-person home visit 2, only teleconsultation 5 for 5 patients, and teleconsultation plus home visit for 3 patients, and follow-up calls of these cases are total 31. In this sector, the child and adolescent population was 1, 18 to 60 age group was 5, and patients in geriatric population were 4, and mean age of this population was 39 years. Totally, we had done tele and home visit for 6 male patients and 4 female patients. Out of them, 3 were married, 4 were unmarried, 1 was separated, and 2 were widowed. It was also noted that all of these patients were unemployed. The main diagnosis of these set of populations were 5 patients with psychosis, 3 patients with mood disorder, 1 patient with anxiety disorder, and 1 patient with IDD and autism spectrum disorder. I wanted to enumerate 3 scenarios which we had encountered in assisted home care project. This is the first scenario where a 17-year-old boy was contacted by his parents with diagnosis of autism spectrum disorder and intellectual developmental delay, with complaints of increased episodes of bedwetting and unprovoked aggression, who was on medication from a private psychiatrist since the onset of the pandemic, with irregular follow-ups without the patient present, where only family were used to go to the private psychiatrist and used to get the medication. Measures taken were we had done teleconsultation for this patient. We had done assessments, and apart from the diagnosis of ASD and IDD, we had also diagnosed him with primary anuresis, and we had suggested them to consult a neurologist and urologist for the same. And family had a specific need for this case as to, like, they wanted the one like psychologist to work with the patient for behavioral issues, but unfortunately because of lack of psychologists in our team, we were not able to provide in-person home-based psychological interventions, but we had provided relevant inputs about behavioral management for unprovoked aggression episodes, and the patient is also being followed up regularly. This is the second scenario where a 45-year-old lady with the diagnosis of treatment-resistant schizophrenia with persistent psychotic symptoms on medication, who was having poor self-care, was also living with her elderly mother, was contacted by her sister, who was taking care of both mother and the patient. Patient was refusing to come to the follow-ups. So they were denied medications by the pharmacists also due to expired prescription. Home visit was done and teleconsultation was also done previous to the home visit for this case. Medications were reviewed and the appropriate medication changes and prescription was given. For psychosocial interventions, behavioral activation has been planned by the social worker of our team, who will be conducting sessions once in a week with the patient. This is the third scenario where where a patient belonged to the geriatric population, 66-year-old elderly lady with the history of type 2 diabetes mellitus, hypertension, and post-bilateral radical mastectomy, who also had the fracture of right leg, that is tibia, presented with low mood, reduced energy, death wishes, reduced interest in daily activities, hopelessness, and also had suspiciousness against the family members. The family members had contacted the helpline. Measures taken were teleconsultation and home visits were done. After initial assessment, we had requested family members to get relevant blood investigations and prescribed appropriate medications. Follow-up of the same case has been being done regularly. These are some of the challenges we had noticed during the inbound calls. Currently, we have noticed that inbound calls are less, and calls we received are mostly from the patients who do not have insight and those who cannot consent for teleconsultation or home visit. And family members request more time for convincing these group of patients for teleconsultation, home visit, and also they take more time to send the consent forms after filling it up. Family members also request the team to talk to the patient as friends or a lay counselor without wanting to disclose that we are mental health practitioners, which would be unethical to do in that case. There can be other legal issues also we might encounter. Example, death, which may arise after the home visit carried out by a psychiatrist and the team. Some technical issues were also noted from the patient end during teleconsultation, and consultations might get delayed in these cases or might have to get postponed. In that case, care might also get delayed. Psychological interventions specifically psychological interventions are needed in some cases. These might not be able to provide due to unavailability of the psychologist in our team, like I said before. Calls have been received from the geriatric population, and people with medical comorbidities will be needing care from multi-specialty settings. So they might have to go to the nearest general hospital settings also. Apart from the mental health care that we provide, they might have to still have to go to the general hospital settings for these needs. We also noticed that there were many invalid contact details provided by the patients in the list that we had received from the BBMP DMHP program. The caller, that is our social workers, have also been questioned about the confidentiality in the previous case where we had mentioned that we do the outbound calls from the list provided by the DMHP regarding the confidentiality when doing these outbound calls, and they have also been scolded by family members for calling them. There might also be increased time consumed for traveling during these home visits. Like only 2 or 3 home visits might be possible in a day, and because of long distance for commuting and the traffic, more home visits in one day might not be able to do in that time. We also expect increase in the number of calls after extensive advertisement, and it might become difficult to manage at present with less staff. There will also be unavailability of the staff on institute and OPD holidays. These are the measures taken to address the challenges. We are trying to assist the patients who do not have insight or cannot consent. These set of population, for them, we are considering the consent from the nominated representatives, and also in cases with the child and adolescent population. Home visit will be done for patients who do not have the facility for teleconsultation or have repeated technical difficulties during the same. Patients will be assured about the confidentiality, and will establish the rapport in cases who may resist to talk to the team, and audio calls will be done in places of teleconsultation in these situations. We have given referrals to the clinical psychology team Nimhans in certain cases, although we do not have a psychologist in our team. We discuss about the child and adolescent patients through panel of consultants from Department of Child and Adolescent Psychiatry at Nimhans. We also do thorough documentation of assessments and treatment to avoid legal issues. We also attend inbound calls on holidays and OPD holidays, institute holidays, and we assure a call back on the next working day to the patients. To manage the increase in inbound calls after extensive advertisement, we require more staff for that. Experience till now, the positive experience are we were able to address the needs of the patients who genuinely benefit from the services, and able to provide timely advice over teleconsultation and avoid delay in care. Necessary guidance has been given in cases who might need acute management or multi-specialty care. We also advise family members to bring the patient for IP care in difficult to manage situations. These are all been done from the guidance from experts in the team for comprehensive management. Some of the negative experiences we have faced is that caregivers, they demand to see the patients in even in the acute conditions, which is an exclusion criteria, and also like threatening to complain to the higher authorities when their demands are not met immediately, or the care is not provided according to their demands. The caller has been scolded by multiple clients when doing outbound calls, which I have mentioned in the previous slide, and not following the instructions as given. Not following the instructions as advised during the home visit and teleconsultations, where the family will get back to us after some worsening, and they will demand for home visit again without following the instructions we had given in the previous visit. And also some patients, they request home visit for reasons like difficult to commute in traffic, to reduce waiting period in OPD, that they have work in office. These are the reasons they give for availing home-based services. This is the helpline you can contact on from 9 a.m. to 5 p.m. on from Monday to Saturday. So you can reach out on AHC Nimhans at gmail.com. With this, I'll be ending my presentation.
Thank you so much, Dr. Bindhu Sagar. Now we'll open it up for questions. As we've got a lot of questions in chat, so I'm going to take that first, and then others who are interested can possibly raise their hands or type in your questions. I also invite my colleague, Dr. Krishna Prasad is there, Dr. Harish Angotu is also there, who's a co-investigator, and my other colleagues from the Department of Psychiatric Rehabilitation Services. We'll go with the first question. The first question was asked by Raji. And Madam asked, can we call AHC regarding medication after effects for mental illness and counseling, though we may be following treatment with some other hospitals other than Nimhans? Dr. KP, would you want to respond to that?
Yeah, I think there is definitely an opportunity to call and seek advice regarding the side effects of medications and take the help of the AHC helpline and the team. But my general advice would be to stick to one person rather than multiple people for consultation, because then both continuity of care and there are chances that things might fall in between the cracks if one single consultant is not seeing consistently. So general recommendation would be to follow up with one person, and then obviously the opportunity to call and seek assistance is there on AHC.
Yeah, so that also includes counseling for mental illness and caregivers regarding the illness and challenges. So that's also done through the AHC helpline. KP, is it right?
Yeah, that holds true for the same as well.
Okay, thank you. So can another from Sri Krishna Badami is, can we have the list of 10 taluks? We will type it out on the chat before we end this program. That will be provided to you. We also have the list of social workers in each of the taluk, which could be shared with you if you require. Mr. Yusuf has asked, please explain the role of the social worker in the PHCs. And also Karthik has asked, Rituraj has asked, please share the role of the PSW, responsibilities in the project and the challenges they face. So Catherine, would you want to talk about your role and the challenges that you face? Yeah. What is your role as a social worker here?
As a social worker, I attend to calls. I give referrals to different institutes if needed, and do home visits and conduct home visits and teleconsultations.
So in the teleconsultation, you basically handle the counseling part of it and looking at the behavior aspects as well as the counseling for the family members and thing, whereas Dr. Bindhu Sagar handles more the medical aspects. Am I right? All right, great. Explain the role of the social workers in the PHC. KP, you want to add in to that?
Right now, I don't think there are any social workers who are working in the PHCs. Under the Taluk mental health program, there is a Taluk level psychiatric social worker who is employed in each of the 10 taluks, and they are primarily working with the people with severe mental illness. And currently, their focus is on educating the family, ensuring adherence to medications, besides, of course, identifying people with mental illness in the community and getting disability certification done, and in some cases, looking at vocational rehabilitation. I think primarily this has been the focus and in the Taluk mental health program at this point of time. Maybe Harish and Shiva, if they want to add anything more, and Aarti yourself.
Yeah, I think from the taluk that I've been associated with, we do facilitate a lot of rehabilitation related work, as I said earlier, from social welfare benefits to vocational rehabilitation, to reducing stigma, to home visits, to help clients to deal with the family to help family members to deal with the clients. We also do this through ASHA workers training and also training other stakeholders, and creating awareness to bring them for treatment, and also providing psychosocial interventions. Dr. Harish, Dr. Shiva, would you want to add in anything from your TMHP experience? Dr. Harish.
Yeah, nothing to add further. I think as Dr. Krishna Prasad said, that I think the role of social workers in PHCs as of now is not that much. But however, as part of the Taluk mental health program, we have seen that their coordination has significantly coordination with various stakeholders and following up people who are discontinuing for the follow-up has made a significant impact.
Thank you, Dr. Harish. We have Amit Singh, who has asked, if this pilot is successful, how do you plan to scale to the PPP model that Dr. Nirmala spoke about, and what role would mental health startups play in the execution? I think the mental health startups, not just mental health startups, but NGOs in the community, as Dr. Nirmala and Dr. Rajani said, can play a large role if we find this pilot to be successful, because Nimhans cannot possibly reach out to the entire country. And we would need a number of partners, including startups, NGOs, the government setups to help us in implementing this all over India. Dr. KP, want to add in anything to what I said?
No, I think first I would want to look at, though initially we looked at it as a kind of, we also wanted to look at it as a research project, but I think we were advised by the ethics committee at Nimhans to primarily look at it as a service as of now, and see if we are in the process of learning from the experiences, see if there are research questions that can be framed. Now, I think there will be several questions which may be asked, both in terms of whether to measure its success in terms of the outcomes. So I think if that is answered positively, I think then probably we'll be in a position to say whether we can scale it up or not. At the same time, I think the government also might look at it from two angles. That is, one primarily from the cost effectiveness of the entire exercise, as well as also probably from the fact that it has to fulfill the mandate of the Mental Health Care Act. So I think both of these will need to be looked at.
Yeah. So Mr. Gangadhar and Roshni Iyer have asked, is home visit covered under the AHC program, which is a big yes. And what are the requirements for home visit? Dr. Bindhu, Sagar, would you want to just reiterate that again?
For home visits, for any mental health conditions, we do home visit, excluding the ones having acute psychiatric emergencies like aggression and suicidality. The patients the comorbidities that patients might be having, like diabetes, hypertension, that should be under control. They shouldn't be having substance use like intoxication or dependence or withdrawal, and they shouldn't be having any legal issues. So these are the set of population we can we cater to the for home visits.
Thank you, Dr. Bindhu Sagar. Can you please share the slide of inclusion and exclusion? Yes, I think we can put it up and share it with you if required. Mr. Venkatesh has asked, can you please explain? Yeah, I think Dr. Harish responded to your question online, which is taken care of. Mr. Karthik has asked, can teleconsultation happen with Nimhans psychiatrist for follow-up if the PMI cannot make it to the hospital? And I think it's a yes, because our teleconsultation team is doing teleconsultation. Plus, if you call up the AHC also, we will guide you on what can be done as next steps. Dr. KP, would you want to add to that?
No, I think all patients who are registered at Nimhans at the first instance are eligible to seek teleconsultation.
Yes.
Similarly, also if they require to consult the AHC and if they meet the inclusion criteria of being within the Bangalore urban BBMP limits and meeting the other inclusion criteria, at this point of time, the AHC team is in a position to provide teleconsultation.
We also have another query from Ms. Debanjana, who writes, is written consent with signature from PMI needed for getting AHC session? Would any of you want to answer? Yes, Bindhu.
Currently, we are taking consent from the nominated representatives when the patient do not have insight or cannot consent. In that cases, after getting consent from the family members, we can do home visit or teleconsultation if they cooperate for the same.
Okay. Thank you for that. We have Ms. Shabnam, who has asked about vocational rehabilitation services. So we do understand that a number of clients are unemployed and require vocational rehabilitation. And at Nimhans, we have the psychiatric rehabilitation services, especially the psychiatric social work team, works for helping in integrating into vocational rehabilitation. The PRS team itself, which is a multidisciplinary team, helps in providing services from engagement as part of daycare to referring to skill training centers. And we also have liaison with companies where we help try to place the client with competitive job employment based on a vocational assessment that we do. So if anybody is interested within Bangalore limits to avail the services, you can reach out to the PRS OPD on Wednesdays, and we could help you out. About vocational rehab services, there are various other NGOs also which are providing vocational rehab services. And I think if you want to get some information, we could also call up our teleconsultation or our AHC, and we could provide you information on that. Dr. Nirmala had a very pertinent question about the DMHP attendance. Ma'am, you want to unmute yourself and ask the context of why you're asking that question?
Yeah. I think I've unmuted myself.
Yes, you are. We can hear you. We can hear
you. The reason I'm asking is, somewhere we are missing the crucial link between reviving the family care model and assisted home care. For example, the whole purpose here is because DMHP, the people drop out as well as attendance is very low, as I'm told. So I just want to know, is that services in DMHP underutilized? If the attendance is low and dropout is there, like I'm told 2 out of 10 is the attendance in DMHPs on an average. Maybe I'm wrong. Maybe it's increased. So what is attendance, at least whether the places where you all visit? What is attendance? If that is the case, why don't you divert those resources? Because cost effectiveness, as Dr. Krishna Prasad said, depends on how you juggle with the resources. Jugglery is very important. If there is attendance, that means all the experts there, mental health professionals there, whether it's a psychiatrist or a nurse or whoever it is, their services are underutilized. On one hand, you have underutilized trained manpower. On the other hand, you have 80 to 90% treatment gap. How do we match the source so that the optimal resource utilization can be done, both for in terms of the care portion for families as well as reducing treatment gap for the country? That is where we have to look at it. There is no point going on reinvesting in things which are like flogging a dead horse, as I say. So somewhere this has to be done, the resource cost-effective aspects of it also, so that when you expand, you don't expand in the wrong direction. That is why I asked this question.
Thank you, ma'am.
Yes, I hope you understand. There is a direct link between assisted home care and treatment gap across the country.
Thank you, ma'am.
Yes, that's why
Dr. KP, would you want to answer that?
Yeah, I think Madam is an important point, but I would also say that I think we are getting to learn something through the Taluk Mental Health program also, in the sense that there are several barriers to that optimum that we want in terms of meeting the treatment gap. And I'm sure that the feedback regarding that would have reached the concerned stakeholders in the government, and they will look at working around those barriers. And we should know that many of the rehabilitation related work that needs to be done will be extremely time intensive. And I think somewhere there is a need also for the assisted home care services. With the existing resources, I'm not sure to what extent we will be able to meet the rehabilitation needs of all the callers that come. Somewhere it has to be linked to the other existing resources like the NGOs or the district mental health program and the social workers and the psychologists employed under the district mental health program. But it becomes a challenge because there are multiple stakeholders then that are involved. So I think getting that linkage right would be the key.
Yeah, and I think that's the main reason that the government of Karnataka also thought we should initially do this pilot and look at how this is successful in Bangalore and then move ahead to expanding so that we're moving phased-wise and then we look at linkages and moving ahead. So I think that was the main logic in which this was.
1 second, Aarti, if you permit me. Dr. Rajani made a very insightful observation that the Taluk Mental Health Program, which is a very good initiative, I think, 40% of the cases could have been avoided had they been given timely attention in their childhood or adolescent stages, which is very, very important. 40%, again, once again, I'm saying 40% is the statistics for the DMHP, but for as far as just imagine the fate of the 40% people in the. So assisted home care, as you have brought out a very important thing. Timely intervention can also to some extent be preventive. Like when you visit family, one person may be actually the person who is already identified as a patient. But in the process, you might find others in the family also, which is quite possible. Your team will find the family pathology, as you all call it. That is very important. I think this is a very big contribution you are all going to make. And I'm very happy to hear that statement from Dr. Rajani. 40% cases could have been avoided is a very significant number, even if it is at a taluk level. It's a human being behind those 40%. That matters.
Thank you. Thank you so much, ma'am. I think Vimala Govinda madam has said, I'm from Mysore, and when are you starting AHC being launched in Mysore? So as you heard Dr. Rajani say, I think we're going to be doing this pilot for another year and a half, and then based on the results, we would be expanding to other areas, because currently with the current resources and the team, we would be able to manage Bangalore. The government is looking at expanding possibly in the next couple of years. We also have questions. Interest to work with people. Okay. What are the legal issues Mangala Jyoti wanted to ask? Dr. Bindhu, would you like to talk about what are the legal issues you mentioned?
Like I said, once the psychiatrists visit the home for consultation, there should be a proper legal framework. Because once the patient dies under the care, like doctor is visiting to the patient to provide care, some certain issues might arise. So for that we have to be careful and also to document in detail about the situation and treatment care and all.
I think, Aarti, the question probably was also in terms of legal issues in the exclusion criteria.
Yes.
I think, Bindhu, do you want to respond to that? I think it is not so much about that death-related query.
Patients or family members having currently ongoing legal issues, they will not be able to, we will not be able to provide care for them. Other patients who do not have legal issues, for them we might be able to provide care for them.
Okay. Mamta madam, welcome. Good to see you here. She's asked, is the number of calls increasing, reducing, or the same? We saw a slight spur in April when we started after the news advertisement. However, the call numbers, would you want to say whether it's increasing, reducing, or because they are the people who are handling the calls? Yeah. Number of calls are the same from April, reducing, increasing. How is it?
Because I just want to know whether it is really reaching, because you gave the statistical figure a fixed number. So I just want to see the graph from Jan to February, February to March, March to April. That only will show the progress in the program.
Yeah, so you'll also need to understand, Mamta madam, that we started only in April. December, all the permissions, the SOPs and all were done. So we are only 4 months down the line. And as others have said, you know, there's not much awareness about the AHC also. So we will be circulating again the AHC to, you know, brochures again. We would request all family members and users to circulate it as much as possible in your group so that, you know, there is more publicity about the whole thing. KP, you want to come in?
No, I just wanted to say that the number of calls have been few actually. And also the fact that whenever there is an advertisement, there is a brief spurt in the number of calls. But I think the number of inbound calls have been few. And I think greater advertisement and communication through all the family support groups like yours should, and all the other family carers should pass the message on that these services are available.
Okay, I think Vimala Govinda madam had another question of how does the AHC team convince the PMI not to discontinue medicine? And KP, you want to answer that?
No, I don't think so. There is a
straitjacket answer to exactly.
Because the reason for discontinuation or non-adherence to medications can be many. But I think in general, a good rapport with the consulting psychiatrist or the mental health professional will be useful in terms of ensuring continuity of medications. So the factors could range from side effects experienced because of the medications to lack of insight to several other reasons, including cost of medications. So and the way the person is treated by the psychiatrist or the kind of rapport the person enjoys with the mental health professional or psychiatrist. So several factors could be contributing to that. I think identifying those and being mindful of those would be necessary to understand the context and then manage.
I think Ambika ji has said, does AHC also give counseling at home? Yes, we do provide basic counseling services. If you require prolonged psychotherapy sessions, I think we do refer you to people as AHC would possibly follow you up. But as of now, we've not gone into detailed psychotherapy related interventions. We have Suresh ji, who's lifted his hand for quite long. Mr. Suresh, please unmute yourself and ask your question. And thank you for waiting so patiently. Please go ahead.
See, I am a member of FACEMI Mumbai, Dr. Nirmala. See, one thing, as for PRS team. Hello?
Please go ahead. Yes, we can hear you. Please go ahead.
PRS team that for 4 months they have worked without a salary. That's a great thing. Really appreciate. It's like about the role of central government. Can you explain how they are supporting? Because I understand Nimhans is getting a good funding from central government. So it is possible for them to do it, practice it at Bangalore for Karnataka. But we are from Mumbai, Maharashtra. So any insight you can share about this, how to begin?
Yeah, thank you for your query. I think a lot of people have, I don't know, a conception or misconception that Nimhans has a lot of money from central government to do additional projects. But I'd just like to clarify that we run a 900-bedded hospital, and to provide the clinical services here, we get the money and funding from the central government and some funding from the state government. So any new project that has to be launched has to be verified and provided additional funding from the central or the state government. And that's what the government of Karnataka has done, has provided some additional funds a little bit to run the AHC project. Now, if we have to do it at a central level, there has to be advocacy enough at the central government level to request them to put it as a pan-India and to invest funds from the central government level to do that. The Nimhans funds which are there are quite enough to handle the 900-bedded hospital and the services that we're doing. KP, you want to add?
No, I just wanted to clarify that the delay in salary was primarily because of several logistic reasons, because this is funded by the National Health Mission, government of Karnataka. So it was primarily because of that. So while working through such collaborative exercises, some of these challenges which are unseen can create problems is the only reason. There is commitment from the government to support this, and that is why it is happening. At the same time, I think it is also driven by the fact that people like Nirmala Srinivasan, who have put sufficient effort to bring it to the government's notice that this is much needed. I think such kind of pressure groups and also some kind of commitment from the government, both are required for this.
Thank you.
Thank you, Mr. Suresh, for bringing up your point, and good to hear you from Bombay. We have a few more questions, and then I would request Dr. Kalyan Sundaramave, senior psychiatrist with us today, to give in some points. Just one or two questions. Ms. Janvi has asked what help is being provided to the family members, especially in the second example Dr. Bindhu spoke about. The woman was taking care of her mother and her sister. I would like to know how you were able to include her in the care, if any.
The sister had contacted us for the patient while patient was staying with her mother, and the maid was appointed by the sister to take care of them. But the sister was coming for the teleconsultations and home visit whenever we needed them. So we were able to manage that with along with the sister's coordination.
Okay, so then the sister was the main focal point for interacting with the family and for helping in coordinating all the sessions with the client as well as the family.
I would like to ask, slightly more question in this. My concern here is that the family is providing the primary care, right? The sister who is providing the care and who is coordinating all the visits for the patient itself. I sort of feel that the family needs support as well. And the question here is, how are we able to support the person who is coordinating, who we are speaking with? That person ends up doing a lot of emotional, financial, social, psychological labor. The person who is doing the family member, the caregiver, the person.
Yeah, we get your point, and I think that's an integral part of our psychiatric rehabilitation services, where we put the family member as the centerpiece of providing psychosocial interventions. Here, one of the main interventions to take care of the care quotient, as Dr. Nirmala said, that's a word that I would like to use again, of the family member, is that the client who is symptomatic, if we are able to handle the symptoms of the client or make them adherent to the medicines, the family members almost feel that, half the job is done. As Dr. Nirmala also said, how do you make them take medicines and so that they can get cured? So the first step to the whole thing is getting them into the loop of treatment, which helps solve half the issues. After that, of course, our social worker works with the family and helps provide sessions as and when it is required. And I do want to stress that this has to be need-based, as Dr. Nirmala said, and it's not necessary that it is required by everybody, because some of the family caregivers feel that we are fine and we don't require those additional services. So as and when it's required, our social worker does provide appropriate supportive work to the family caregivers or informational support to the family caregivers. Yeah, please.
We had also inquired about the issues that you had brought up with the sister, but sister is currently is able to manage both mother and the patient. She said that she will get back to us whenever she requires any help for her psychological helps.
Thank you, Dr. Bindhu Sagar. I think we are running a little late. It's 3:44 and we'll need to close quickly. Viren has asked, what are the long-term impacts of continued psychiatric medicines? I'm not sure whether it's under the ambit of AHC, Are they addictive beyond a certain time? Is it advisable to move to counseling? I think there's a huge debate on its own, and it has to be case-based, and we will not be able to make a generic statement, Brain. So if you need further help, you should contact a psychiatrist or a counselor who could possibly reach out to you, or maybe call up the AHC helpline. Dr. Krishna Prasad has put the AHC helpline on the chat box, so please make use of the AHC helpline, which is in the chat box. We have one last question from Ms. Saraswati, who's raised her hand, and then we move on to Dr. KS. Yes, Ms. Saraswati, for a quick point from your side. Please unmute yourself. You have to unmute yourself.
Thank you very much. This is, I'm also from Mumbai FACEMI. And, in a continued question from Suresh Ji, what I wanted to ask is, how would you all, as the Nimhans, would be able to help the Maharashtra government in setting up the AHC?
I think, as I said, we are right now piloting the AHC on our own. And you will need to look at how the Maharashtra government reaches out to the Karnataka government, because the Karnataka government is the one who's supporting the work here, to see if they want to learn from the models and then implement it over there. I'm not sure whether Nimhans can directly do that, but possibly we can provide technical support and the model that we're doing here, but it has to come in from the Maharashtra government.
Yeah.
Maharashtra government to our Karnataka government.
Karnataka government.
Yes,
Thank you
yes,
so
yes.
much. Thank you so much.
Yeah. Yes. Do we? Yeah. Now, I think. Thank you, Dr. Vijay Nalawala, for being there in the session. I mean, it's wonderful to have you on board. I'll hand it over to Dr. Kalyan Sundaram for a quick few remarks, sir, as a senior psychiatrist, and then we will summarize and conclude. Yes, sir. Please go ahead.
Thank you very much, Aarti and team, and also to Dr. Nirmala Srinivasan. I kept raising my hand, somebody kept pulling it down. I did not know whether it was my technical incompetence or somebody was smarter there in Nimhans to keep removing my hand. I thought I might just miss the bus. First of all, I would like to compliment Dr. Nirmala Srinivasan, whose other name is Tenacity. And the Aarti
Thank you.
For joining hands and doing this wonderful initiative, which is long overdue. Time I encountered something similar in a place called Trieste. Some of my mental health colleagues will probably know what is called the Trieste experiment, which for the first time in the world, in Italy, in a place called Trieste, they opened the mental hospital way back in the 70s, discharging all the patients overnight. And they did not stop there, and they followed up with a assisted home care. Now, I happened to go and see the hospital much later and also went and saw their program. Very impressed. And I always wondered whether with our population and the kind of a less number of professionals we have, whether we will ever be able to achieve that goal. I'm happy to see this is happening. The slides were very nicely portrayed. I want to caution all the, both the speakers, caution all the participants. The program is not as easy as it looks on the paper. It's a lot of work, lot of learning. They've done it for 4 months. I think over a period of time, all the teething problem will emerge and we will find more and more issues to be tackled. I think in the initial stages, it may look good, but I think it's a lot of difficult humps and troughs we have to climb and go down. But eventually, I'm sure the team will find a foolproof method of making it happen. If ever there is something called foolproof in mental health management, a pipe dream. I'm not sure whether I missed out. Do you take on people who are asking you to come for the first time to their homes? Or is it only always a follow-up? You may answer later in your winding up. Oftentimes I see the discussion on discontinuation of medication. Please understand, in severe mental illness, especially something like in schizophrenia, the relapse rate is about 80 to 90% across the globe. In my 50 plus years of working as a psychiatrist, I've not seen a single patient who has not discontinued medication at least once in their lifetime. So it's a huge problem. People also asked, how do we convince people to take medication? I'm one of those proponents of what is called long-acting injectables. We in this country use it very much less than it is required. The world average is about 10 to 15%. In India, it is 10%, which is, if at all, it's a very tall claim. We are not using long-term injectables of any choice of the doctor because it prevents relapse, it prevents non-adherence to a very great degree. I think we should look into it. In fact, one of the aims must be when the team goes, if there's a long-acting injectable due on that particular visit, the injection should be given at home if they are not able to come to any center. It's a very important aspect of managing at home. We know it's a brain disease, so we have to be very cautious. Dr. Nirmala made a remark, may not need medication. Some people say that. I would be very cautious in using this remark. I think most, if not all people with an established diagnosis of schizophrenia, as an example, will require medication lifelong. I don't think we should take it lightly because less treatment, more relapses, more brain damage, extremely well established. Dr. Aarti and team, you said the evaluation form, as we're waiting to hear that. I'm glad you did mention it. You said once initially and then 1 year later, why not somewhere in between also, is my question. If you have got an established team, I think you may want to do it little more frequently. I don't know, 3 months, 6 months, 9 months, whatever, because you will know at what point in time we are reaching the plateau. Nephrologist or your neurologist, I think it is not a question for debate. Both need to be there. Epilepsy may be a possibility. Dr. Harish, I agree with you. But there may be other things, simple things like urinary tract infection, other things. I think it's not an either or. I would believe both would be required. Both are important. Death, after seeing the psychiatrist, I took a double take. But I realized what they meant is if something happens after the psychiatrist visit, there may be legal issues. I think one has to cover our backside, so to speak, and legal implications have to be understood very clearly. The Nimhans team is very well experienced in this issue. I'm sure they will understand this. I would like to use this as a last point to say this is something like the last mile connectivity. Something like the last mile connectivity we talk about when we use our metro rail transportation services. What happens between the station and reaching home? This last mile connectivity with the doctor, the therapist, social worker, and the team, and the family, and the patient not being able to reach. This will provide the last mile connectivity, and non-cooperation from the family, non-cooperation from the patient can be a very trying time. The team will have to have enormous patience and a clear support system, hierarchical support system to provide the kind of support they need, because very easy for them to get frustrated. But you go with all the enthusiasm, you find the response is not as adequate or expected. It can be very trying. But I would like to caution the youngsters sitting there. You're all doing a fantastic job. I'm sure you will do very well with the guidance of Dr. KP, Harish, Shivakumar, Jagdisha, and Aarti, of course, as a spiriting the team. Very proud to have you all there, doing a fantastic job. Look forward to your further reporting. Let's say after 1 year, this is what you did for 1 year, and this is what we have found at the end of 1 year. What are the learnings? Where do we go from here? Thank you very much for your patience.
Thank you, Dr. KS. Dr. Nirmala, you wanted a minute, so we'll give you a minute because we're really running really late. Please go ahead.
Convey my sincere compliments. Very proud of all of you. Please introduce the eSathi app. It should be an exclusive. We have already designed. Maitri has done it with IIITB informally, not at a formal level. Dr. Rajani is aware of it. This eSathi app has exclusively for assisted home care. It will. We can talk about it later. I just thought I'll announce it here. If you're all interested, we can go through it. It has a lot of filters. It will be it save your time a lot. And it also helps the family members to be very clear on why they are calling you, why, if at all, they have to approach AHC. So I thought I should share this information before you close down. Thank you so much, Aarti, from my side, for giving this wonderful opportunity to be with so many people. Thank you so much. And thanks to Dr. Kalyan Sundaram and Dr. Krishna Prasad and others in the group. Thank you.
Thank you. Thank you so much, Dr. Nirmala. So just summarize, I think the assisted home care project, which has been outcome of the advocacy of family caregiver groups. We are looking at not emergency care. We are looking at providing assisted home Medicare. And to some extent, rehabilitation also. I think we flashed the helpline contact details and the AHC email. So please feel free to reach out to us. People who have asked us questions on the 10 TMHP taluks, I would request you to send an email to us so that we can respond back to you with any queries that you have. And Dr. K has asked us whether we're doing only follow-up, but we're also taking new clients who want our help, and also follow-up clients. So both are included in the AHC team. And we would possibly like to come back after a year and see how the data goes and how successful the pilot has been to take further conclusive decisions on how to move ahead. I thank my entire team, Dr. Krishna Prasad, who's my co-principal investigator, Dr. Rajani, Dr. Harish, Dr. Shiva, Dr. Shanivaram Reddy, my other colleagues in psychiatric rehabilitations, Dr. Jagdisha sir, and my team over here who's coordinated the AHC team, Dr. Bindhu, Sagar, Catherine, Yogesh, we have Ramya and Aguno who have coordinated the entire program for today. And of course, Dr. KS, who's joined in today as a senior psychiatrist. Thank you, Thank you, Dr. Nirmala, for agreeing to be part of this program, and a lot of other important stakeholders from Amend. I know Bipolar India, Dr. Vijay Nalawala is here, Ms. Mamta is here, and thank you very much all the users and family members for joining in. The recording of this would be available in YouTube, Gono, in some point of time, and they will help in facilitating that, and it would be accessible to you in some point of time. Thank you. We will close.
Aarti, I just want to mention,
yes,
the catalyst for the whole program, in addition to your team, is Dr. Rajani. I think without the government's continued support, I think this may not have happened. I think it's an excellent cooperation between Nimhans and the government of Karnataka. I think that's the way to go. Wonderful.
Yes. Yes, thank you. Thank you so much, Dr. Kalyan. So that summed up really, really well. Thank you. Namaskar, and we'll close for today. Thank you.
Bye, everybody. Thank you. Bye.
Thank you, everyone.
என்னடா
என்ன பண்றது?
சும்மா வந்து மேல விழு. போய் அவன் மேல விழ அந்த ஹெல்ப்பாவது பண்ண. இவ்வளோ கஷ்டப்படுறாங்களே. ஹோம் கேருக்கு கூப்பிடுறதுக்கு ரெடி பண்ணிருக்கிறேன். யாரன்னா கூப்பிடணும் ஹோம் கேருக்கு அவனை கவனிக்கும். என்னடா இவ்வளோ அசிங்கமாயிட்டு இருக்குது வீட்டுல இருந்து. ஐயா சி ஆபீஸ் போகும்போது பாரு என்ன நல்லா இருந்துச்சு இல்ல சொல்லு. ஒத்து தோசை இது வடை சுடணும். ஒத்து பானு ஃபோன் பண்ணி கூப்பிடுச்சுன்னா வந்துட்டு ஓட்டுக்கிறீங்க வாங்கக்கா குங்குமஞ்சா வச்சுக்கோ. ஏன் சொல்
ஒண்ணு மாதிரி பண்ணி மாதிரி இருக்குது.
குங்குமஞ்சா ஏன் சொல் வச்சுக்கணும். பிளஸ் பண்ணும். பிளஸ் பண்ணா அவ்வளோ நல்லது. இன்னைக்கு பெரியவங்க கிட்ட எல்லாம் பிளஸ்ஸிங் வாங்கினா அவ்வளோ நல்லது. என்னத்துக்கு இப்படி ஊற பண்ணிக்குட்டி. இது என்ன பண்ணியா இது என்ன இது இப்படி ஊறுது. எலும்பு முடிஞ்சிட்டு இருக்குதுறானா அங்கேயே வந்து எழுத்தறிய. என்ன பண்ற தேவையில்ல தானே உனக்கு. மொபைலு ஃப்ரெண்ட்ஸு போட்டோ. இது மலையாளி இது போட்டுக்கிறாங்க பாரு மானசாமியா நல்லா இருக்குது. உனக்கு மலையாளம் பிடிக்கும். அது ஆன் பண்ணு. அது லெஃப்ட் மானசா பாரு. மானசா சரோவரன்றது இவங்களுக்கு ஒரு வாட்ஸ்அப். போட மானசா வடை செஞ்சுட்டு அவங்களுக்கு குடிச்சிட்டு ஒரு ஆயா கூட்டின்னு வந்து அதுகிட்ட பிளெஸிங்ஸ் வாங்கிக்கினேன். வைக்கிறதுல ஆயா பாட்டி தாத்தா உட்காந்து நிற்கிறாங்களே அத்தனை மெதுவா கூட்டின்னு வரணும். மாமா பத்தில பார்த்து வச்சுக்குவேன். ஒத்து போய் பண்ணலாம்.
இல்ல கருத்து நான் பொழுது பேர் பாத்தியாடி பண்ணிக்குது.
என்ன போட்டுக்காம என்ன அது கிட்ட காமிச்சா தானே கண்ணு தெரியுமா எனக்கு. இந்த ட்ரெஸ் தான் காமி.
இன்னைக்கு அவங்களுக்கு வெட்டிங்.
யார் சொந்த
பாட்டுக்குது பாரு கீழே
பாக்குறேன்.
சோமேஸ்வரா டெம்பிள் போயிட்டு வந்தது.
கண்ணு தெரியுது இல்லடா எனக்கு. கண்ணாடி போடணும். நல்லா இருக்குது இல்ல அழகா. ஒத்து மினி ஹாப்பி ரிட்டர்ன்ஸ் ஆஃப் த டே போடலாம் இல்ல. மினி
இது வேணாம் இரு நல்லா போடாது.
உனக்கு எதுக்கு போடணும்டா. பக்கத்துல இருக்கிறவங்க அல்லோ அல்லோன்னு கூட பேசுறது இல்லைன்னா எப்படி குடிங்க. ஏன் இப்படி இன்டர்ஃபியர் ஆகுற லைஃப்ல நீ. யாரோ ஒருத்தர் விடு ஸ்வீட்டி பூட்டின்னு எல்லாத்தையும் கேட்டுக்குவேன். நான் சொல்றது செய்ய மாட்டேன். போடுது அது போடு மினி ஹாப்பி ரிட்டர்ன்ஸ். இது என்னடா இது போடு.
ஸ்கூல்ல வேலை பண்ணிருக்கா இது.
ஆமா
என்னவா
டீச்சர்.
என்ன டீச்சர்?
பேபி ஸ்டூடெண்ட்ஸ்க்கு எதுவும் வேண்டாவா. யாரும் பண்ணக்கூடாதா. போடுறாது ஹாப்பி ரிட்டர்ன்ஸ் ஆஃப் த டே.